S is missing somehow, then I is high likelihood of therapeutic success by adjusting the dosage. You just increase little bit dose and there will be success. And R is high likelihood of therapeutic failure, but not zero. This is the resistance. In some situations of resistance cases, therapeutic success achieved in up to 60% cases because of the host mechanism. So interpretation is very important, and why we were selecting the most appropriate agent, we should know the MIC. What is the MIC? Numerical value. Second is antibiotics break point. Antibiotics break point is very important. You can see in this picture, the last picture, you can see the MIC of the first drug and MIC of the second drug. MIC of the first drug and break point is 3 dilutions away from the break point. And second picture, MIC is 4 dilutions away from the break point. And this is very important. How far the MIC is from the break point. So if it is more dilutions away from the break point, which is more sensitive. If it is less away from the break point, it is less sensitive. So site of infection is also very important. What is the achievable drug levels at the site of infection? Then age of the patient and health, whether patient is suffering from non-organ disorder, the immune status, what is the immune status? What is the mode of action of drug? Whether it is bactericidal or bactericidal drug? What is the spectrum, broad spectrum versus narrow spectrum? What is the pharmacokinetics of drug? And what is the antibiotic guidelines of the country? And what is the safety and contraindication? And most importantly, how you can use frequency and route of administration, whether it is very easier to use the antibiotic. Now, BMQ is given in some of the labs, like Lalkar used to give BMQ and so on. BMQ is the ratio of clinical breakpoint MIC to MIC of organism. Mainly, breakpoint to MIC quotient. Suppose antimicrobial A has MIC 0.5, breakpoint 2, antimicrobial B has MIC 2 and breakpoint 60. If you divide breakpoint upon MIC, it is 8 for antimicrobial B and it is 4 for antimicrobial A. So this antimicrobial B is higher BMQ and there will be better clinical response of antimicrobial B because of BMQ is higher. So that's why whenever you see a report on BMQ, you can correlate with that report. Otherwise, most of the labs don't give BMQ. Only one lab I have seen that giving the BMQ. Now here is the 5-year-old child, high-grade fever, leukocytosis and significant 5-year event. Red culture sensitivity shows the 40 E. coli and sensitivity is as well. Is this proper report? Can I interpret the report? Is this proper report? How many are in favor of this? This is the proper report? No. Very good. So, if you do the culture interpretation, friends, this was the previous one was the incorrect way of reporting sensitivity. Number of pluses depends on the zone size. Larger the zone, more number of pluses. The zone size should be compared with the standard guidelines which are available. I just said two guidelines are available, UCOST and CRSI, which give the standard diameter of zones. If zone obtained larger than sensitive drop point, organism is classified as sensitive, and lesser than resistant drop point is resistant. Now come to urine culture. Collection with the midstream in older children. You should take the clean catch specimen, and you should wash the genitalia with soap and water, and then take the discard 2 drops and take the midstream urine. Or you can take the clean catch specimen, and in situations where required, you can take the suprapubic aspiration in urines wherever required, or children where it is not possible. Immediate transport to lab. Urine should be transported within 1 hour, within 60 minutes, because most of the organisms will die during the after it is transported in the temperature for longer than 60 minutes. So interpretation is if there is a 2 or more organism, it shows contamination. A single organism with chronic count of 10 over 5 per ml is significant. For suprapubic, any organism is significant, and for catheter sample, it is 10 to the 4. Always interpret in light of clinical symptoms and urine routine reports. This is very important. So urine culture interpretation, common pathogens are E. coli, Proteus, Enterococcus, and always correlate with human analysis like how presence of WBC, nitrites, leukocyte and antibiotic sensitivity report. Always use standard format and avoid using non-standard symbols like pluses. You should see the MIC values and what is the base interpretation and CLSI and UCAS guidelines. In blood culture interpretation, you should identify the argument whether it is true pathogen or possibly contaminants. Number of positive bottles is very important. Multiple positive bottles, this means strongly severe infection. Only one of four positive means possible contamination may be there. TTP, time to positivity, is also very important. It is less than 24 hours, possibly true bacteria. You should always interpret in context, the clinical context. You should report sensitivity. And remember, friends, always take two or more sets of culture from different sites for better accuracy. But remember, initially it was told that you should take at least 30 to 60 minutes interval, two intervals, but multiple studies have been done and has been shown that there is no difference in recovery of the organism whether you take at the one instance or different intervals. So antigen detection. Antigen detectable right at the onset of disease, useful on prior antibiotic therapy has been initiated and cultures are negative after 24 hours of infection. So many tests are available.